A very, very wonderful morning to each one of us. Welcome to another interesting webinar under the aegis of Mumbai Hematology Group. Today's topic is HLH, and we assure you it's going to be another exciting one. It's all because of Mumbai Hematology Group and because of our program director, none other than Professor Dr. M.B. Agrawal sir. We all know him very well. He's professor and head department of hematology at Bombay Hospital and also consultant hematologist at Leelavati Hospital and Brij Candy Hospital. Those of us who know him extremely well, an institution in himself, an inspiration for many teachers of teachers. Wonderful webinar, sir, all because of you. May I request you to take it forward from here.
Thank you, Dr. Manoj. So friends, good morning to all of you. Our guest speaker this morning is Dr. Rafal Mahowicz from Warsaw, Poland. He's going to speak to us on HLH. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS and managed by Mice Ideas. I thank Dr. Manoj and his team from INTAS, Mr. Rajesh, Mr. Kalpesh and their team from Mice Ideas, the Executive Committee of Mumbai Hematology Group, the Chief Guest, Dr. Sandeep Shah from Ahmedabad, our guest speaker, Dr. Rafal Mahowicz from Poland. All our discussants were themselves eminent hematologists or physicians from India, and you participants for sparing your Sunday morning. Almost 400 of you have registered, 300 from India and 100 from about 10 to 12 countries all across the world. 1/3 of the participants are fellows or trainees and 2/3 are the seniors. Just to tell you about our next weekend activity, Friday evening 7 p.m. onwards, we have an update on factor 9 deficiency. Saturday 7 p.m. onwards, we have monoclonal gammopathy of renal significance by Dr. Nelson Leong from Mayo Clinic, Rochester, Minnesota, US. He has coined the term monoclonal gammopathy of renal significance, has been working on this field for almost 2 decades. Sunday morning, 11:30, we have Dr. Antonio Piga back with us. And this time he is covering the subject of fertility and bone disease in thalassemia. So that's our next weekend. It's my pleasure to introduce our guest speaker for the day. Dr. Rafal Mahowicz is a specialist in HLH. He works in the Department of Hematology, Transplantation and Internal Medicine, University Clinical Center of the Medical University of Warsaw, Poland. He studied in parallel medicine, graduated as MD, and individual interfaculty science studies, graduated as MSc in biology. Since 2010, he is involved in the patient care and clinical research in the field of adult HLH. He has co-authored many important HLH manuscripts, including recommendations for HLH management in adults, recommendations for use of etoposide-based therapy, and bone marrow transplantation HLH. In EBMT, he initiated and performed analysis of hematopoietic stem cell transplantation results in adults with HLH. Author of book chapters, manuscripts, and conference presentations raising HLH awareness among physicians treating adult patients. And this is probably his most important contribution of teaching the internist how to suspect, how to diagnose, and manage HLH to decrease its mortality. Member of the Histiocytic Society HLH Steering Committee since 2019, and since 2020 is member of the Young EHA Committee at European Hematology Association. To introduce today's discussants to you, we have a galaxy of them from various parts of the country: Bangalore, Delhi, Srinagar, Kochi, Sikandarabad, Manipal, Chennai, Kolkata, Ahmedabad, Chandigarh, Surat, and Kolkata. We're Dr. Sharad Damodar from MSMC, Narayan Health City, Bengaluru. Dr. Pravas Mishra from Max Hospital, New Delhi. Dr. Javed Rasul from SKIMS, Srinagar. Dr. Neeraj Siddharthan from Amrita, Kochi. Dr. Mukul Agarwal, AIMS, Delhi. Dr. Karuna Kumar K from Yashoda Hospital, Sikandarabad. Dr. Rucha Khanna from Kasturba, Manipal. Dr. Pratibha Singh from Apollo, Chennai. Dr. Nidhi Dixit from Apollo, Kolkata. Dr. Nidhi Jain from Zydus, Ahmedabad. Dr. Deepesh Lad from PGI, Chandigarh. Dr. Hasmul Balar from Surat Hematology Center, Kiran Hospital, Surat. Dr. Mopali Ghosh from Institute of Hematology, Kolkata. Now we come to the Sunday quiz for the postgraduate students. Today's quiz is related to hepcidin. We will be showing you a picture. Now we will show you 11 conditions which either down-regulate or up-regulate, that is increase or decrease the production of hepcidin. One of the condition has been marked with a wrong arrow, and you have to email us the number of that wrong statement or picture. I will tell you more about it when I show you the picture, and that number 1, 2, 3, whatever it may be, you'll be mailing it to mbagarwal1@gmail.com, and whoever mails of course, all those who mail the correct answer, their names will be announced after the lecture from Dr. Mahavich. But the fastest finger fast will be the winner and gets the prize as usual. Now this is the picture, and I'll explain you this picture before you attempt. You've got hepcidin in the center. You've got various conditions which increased its production, labeled as plus. And you've got various conditions here which decreased its production, labeled as minus. Now, one of this condition is wrongly placed either in plus or minus. So there are total of 11 conditions, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So you have to pick up the numbers. For example, if this is a condition which does not increase the level of hepcidin, then that's the wrong statement, and you will be emailing 1 as your answer. All right. So that's the background, and now I will show you the whole picture. So 5 conditions have been labeled here as increasing the hepcidin production: kidney disease, dialysis, or merely decreased GFR. Second one is RBC transfusions. Third one is administration of iron, IV or oral. Fourth one is replete iron stores. And the fifth one is genetic conditions, TM-PRES6 variants. Now, I'll tell you the 6 conditions which decrease the level of hepcidin: ineffective or expanded erythropoiesis, anemia, hypoxia, especially iron deficiency, erythropoiesis stimulating agents like erythropoietin or darbepoetin, chronic liver diseases with decreased synthetic, infections and inflammations, and lastly, genetic factors like variants of hereditary hemochromatosis genes. So the picture says that these 6 conditions decrease the production of hepcidin, and these 5 conditions increase the production of hepcidin. But one of these 11 has been wrongly placed. So that particular number we are going to email to mbagarwal1@gmail.com. And the one who is fastest finger first will be the winner, and the other's name will be announced. Our chief guest of the day is Dr. Sandeep Shah. He doesn't require an introduction. He has been partnering all our webinars for the last 2 years. His consultant hematologist and bone marrow transplanted in charge of BMT department in Department of Medical Oncology at the prestigious GCRI. He's also at Hemato-Oncology Clinic, Vedanta Institute of Medical Sciences, Ahmedabad. He was trained in bone marrow transplant at Royal Free Hospital, London, way back in 1998. And I must say that whatever little ABC of bone marrow transplant I know is courtesy Dr. Sandeep Shah. He has received a number of orations and he has delivered over 30 guest lectures. He's published over 50 peer-reviewed articles in international and national journals and chapters in the books. His areas of interest are various types of stem cell transplants, thalassemia, aplastic anemia, and chronic myeloid leukemia. So I request Dr. Sandeep Shah to inaugurate today's webinar and give some words of wisdom for our young fellows. Thank you. Over to Sandeep. Sandeep, unmute.
So, thank you, Dr. Ambivara, and I would like to thank you for starting this great academic endeavor during the pandemic that has benefited many young minds, especially the residents of hematology and oncology. I also thank you for making me chief guest for this prestigious event. Today, I am supposed to speak a few words on the prospect of the branch, which I have practiced for the last 35 years. Hematology and oncology is the rising sun in medicine, and there is a great potential to this branch that is still in its infancy. So for such a large population country, the number of trained hematologists and oncologists are meager, and there is a need to increase the numbers of trained specialists in this field. India is a large country with huge population, around 130 crore, and the number of transplants are not even 3,000 per year. I will give you an example. Gujarat and United Kingdom, the population is around 7 crore. The number of transplants in Gujarat has still not reached 125 per year. And compared to that, in United Kingdom, it is more than 5,000 transplants. Similar is the case for the whole country. The number of transplants are still not reached even number 3,000. So gone are the days where medical oncologists used to cover the whole spectrum of oncology and hematology. Today we have adult medical oncology, adult hematology, pediatric oncology, and transplant physician and transfusion medicines all are subspecialty of hematology. So medical oncology and hematology are changing at a rapid pace thanks to the advances in molecular diagnosis and molecular genetics. There are numerous new drugs and targeted treatments are coming to the market every single day, including immunotherapy and CAR T-cell therapy. More drugs are approved by the FDA each year in hemato-oncology than any other specialty. The molecular mechanism that we read in books 20 years back when we were starting our practices now can be targeted by novel molecules. This rapid development of our field truly make us the rock stars of the medicine, and these rapid advances have also helped improve prognosis of patients by doubling survival in most cancers as compared to 10 years back. And this stride of success will continue with the rapid pace of research in our branch of hemato-oncology. Also, sir, I will also agree with you will agree with me that there is a great personal satisfaction to this job. And this is the reason why I still work full-time in this field, although I just completed 60 and I cannot think of retirement when I see you stalwarts like Dr. Sunil Parekh, Dr. Mehman Chandi, Dr. Pankaj Shah, Dr. Advani, Dr. M.B. Agrawal, and Dr. Tapan Saikia. And I cannot think of retirement when I see that these people are working even after completing 65 years. And I like to salute them for their relentless efforts and contribution to this field. However, the time has now come for young blood to take the reins and take this branch to the next level. Even in teaching institute, there is a great potential for youngsters taking this branch, and they can rapidly rise to the ranks of academia. And now let me say some words of wisdom. The primary motive of practice should be the patient's health first, patient's well-being first. And believe me, the money will come as a side effect. If you practice good medicine, money has to come as its side effects. The power of a doctor lies in his ethics and his patient's confidence. As they say in cricket, form is temporary, but class is permanent. So in our practice, ethics are our class, and we are here to practice for 30 years, 35 years, and not 30 or 40 months. There is also a great responsibility on government doctors to practice value-based medicine and not misuse the evidence-based medicines, as we still are developing country and optimal utilization of resources are important in country like ours. India needs a value-based practice where the cost-benefit analysis should dictate our uses of medicines, or we will end up as a bankrupt healthcare system like other few countries. To end, although I came to this branch not by choice, by default, and I am still enjoying my practice and my career in this field. And I am sure that if you select this branch as your choice, you will not regret and you will also enjoy your practice. Thank you, Dr. Var.
Thank you.
Again, and thank you for giving me this opportunity.
Thank you, Dr. Sandeep, for inaugurating our webinar and for those very, very kind, inspiring words. I agree that these are words of wisdom and will make a great impact on all our colleagues and especially the juniors to whom your message was loud and clear. Thank you so much. And now we have our guest lecturer. I can already see Dr. Rafael has already joined. So Dr. Rafael, it's all yours now.
Thank you very much for this kind introduction, and thank you very much for inviting me. It's a great pleasure and honor, and I've heard before about Mumbai Hematology Group from a doctor from India who works in our department, Piyush Vyas, and I know how important it is and how much great work it is for education. Okay, now I will share my screen. Okay. Okay, can you see my presentation now?
Yes.
Great. Okay. Yes, so I work in Department of Hematology, Transplantation and Internal Medicine in Medical University of Warsaw.
Sorry for the interruption, sir. Sir, please make it full screen.
Slideshow mode.
Okay, in my computer it is in full screen. I will try once again. Is it now?
Not yet.
Because okay, so maybe I will share once again. Because in my computer it seems to be working. Maybe I'll try a sharing screen, not the presentation. Okay, and now?
Not yet. Yes, perfect.
Okay, great. Because I shared a presentation, not just this, not the screen, literally. Okay. So now you can see. Great. We can move on. Okay, this is my conflict of interest. And now to the point. Hemophagocytic lymphohistiocytosis, HLH, is a syndrome of self-accelerating hyperinflammation. In some individuals, if inflammation reaches a high enough point, it doesn't end by itself. It gets self-accelerating until it kills a person, because we cannot get greater and more intense inflammation till infinity. At some point, our body just refuses to strive, and this is because there are positive feedback loops which are independent of the trigger of this inflammation. meaning that something started this inflammation and then it's going by itself until it kills a person. So it's a deadly syndrome because if it's not stopped, it will kill all the patients. And it's important that it's a syndrome because those triggers are multiple. We will discuss them in a minute. So it's not one disease, like you've got Mycobacterium tuberculosis, it causes infection, and then you've got tuberculosis, this is one disease. And here we've got multiple triggers which can lead to same syndrome. That is why it's a syndrome. Fortunately, it is rare, about 4 per million per year, but these are data from Sweden, and this is in adults, and this is only for HLH triggered by malignancy. And we've got also other triggers, maybe a bit spoiler, but there are, it can be triggered also by infections and autoimmune diseases. So it will be more patients. It's still underdiagnosed, especially in adults. And I will, as an adult hematologist, I will focus mostly on adults, but there will be some topics also relevant in pediatric hematology, as this syndrome was first described. In fact, it was first described in adults, but generally it was first developed, the treatment and well known as a syndrome in children. And this was great work of many people, but Professor Grita Janka from Hamburg had a very, very great work there. So in pediatric hematology, this is a well-known disease, a syndrome, whereas in adults, in virtually probably all places, it's still underdiagnosed. And as it leads to death of all patients, if it's not diagnosed, at this point, the most important thing is to know that it exists and to know when to suspect it and try to diagnose it. But of course, avoid overdiagnosing and overtreatment. So when to suspect? What are the symptoms? Signs of inflammation, because it's hyperinflammation, and of course they are increasing. So there will be prolonged fever, cytopenia, organomegaly. Also there can be rash or jaundice, and some people get central nervous system involvement. It's more more often in children, but it also can happen in adults, both as there is also possible isolated CNS HLH, but it's really difficult to diagnose. And in lab results, the only single parameter which can lead us to HLH is hyperferritinemia, but extreme hyperferritinemia, meaning several thousand nanograms per milliliter, but frequently above 10,000, 20,000, it can reach several 100,000. So if we see such results, we should think of HLH. Of course, there are many other reasons. For example, mushroom intoxication, like amanita mushrooms and or acetaminophen toxicity in suicidal attempt, for example, when there is lysis of liver and it releases ferritin in high amounts. But of course, then we have no fever, we have patient history, and we want, and even though there can be ferritin of 100,000, no one would think of HLH, rather about a liver transplant. But very high ferritin should always raise suspicion. As ferritin is as a test is suited to diagnose iron deficiency anemia, it's very accurate in small values. It's very important, do we have ferritin 3 or 30? So this test is very accurate in small values. In high values, there is a problem. It stops usually at 2000. And ferritin above 2000, it can be 3000, it can be 300,000. So it's good if you have any suspicion, or if you have resources for this. By default, all results can be diluted. You dilute the sample to obtain this test in the same machine, but from diluted sample. Of course, such dilution causes some inaccuracy, but if you have 11,000, it's about 11,000. You don't have to be that precise. So in some places they never get so high ferritins because their test is they don't dilute the samples. So this is an important thing to do. Okay, and there are other things which are then in diagnostic criteria. Maybe elevated transaminase and LDH are not okay in one way of diagnosing HLH. They are included. So why does it happen that people develop such response? Can you see my cursor? Like with a red spot? Great. Okay, just to double check. Okay, so one of the triggers can be EBV, and there are two ways, like normal above. So we've got T cell activation, CD8 T cells, and there is infection. They go higher, and then the infection and the immune response, the response ends, and there are still some memory T cells. Whereas in some patients, there is block in cytotoxicity. We'll discuss it in a second. And then we've got a lot of cells which want to attack the enemy, which in EBV infection, like you cannot really kill a virus because it's already not alive, but cells kill infected cells. And they cannot do it because of their block in cytotoxicity, but they can produce cytokines. And usually there is a positive feedback loop. We've got some of them, like but of course positive feedback loops are very good for fast augmentation of response, but they have to end at some point because we cannot go to infinite. And here there is a problem because the lymphocytes T activate macrophages, which activate lymphocytes T. And here we can see that when lymphocytes remain activated, because they cannot kill the cells, they produce cytokines all the time, and then they get another activation from macrophages. So we've got those positive feedback loops which cause HLH. And activated macrophages, are associated with hemophagocytosis, and we'll discuss it in a second. Okay, so we can see here cytotoxic granule pathway. So those granules get from endoplasmic reticulum, then they are polarizing, there is maturation, polarization, docking, and finally in a strategic moment, when a cell wants to kill another cell, they are degranulated and cause apoptosis of target cell. And the most classic variant of lack of the cytotoxicity is mutation when there is no perforin. So this is FHL2 syndrome. When there is no perforin, granzymes cannot penetrate target cell. And this will cause HLH in very, very young age. With first infection in several month-year-old or several week-year-old child. Of course, in adults, this is not the case because adults used to be children for 18 years and didn't develop HLH and have seen some minor infections. But adults can also have some polymorphisms or mutations. And then we have to be very cautious with qualification for allogeneic stem cell transplantation, because those variants can be just population variants, and if we find just polymorphisms. If we find it and then someone has HLH due to some other reasons, and it can be, and this polymorphism of course can help a little bit, but we can overtreat someone with allogeneic stem cell transplantation, which can have some big consequences. And there are multiple genetic disorders associated with HLH. And what I recommend, there is Gene Reviews website in US in Seattle, I think it's that university since 1993. They have this website. It's free, and you can check all the genes, genetic diseases there. And there is very freshly updated chapter about familial hemophagocytic lymphohistiocytosis. So it was. It came on last days of September this year, so it's very fresh, and you can get information about familial HLH there. Because we don't have time enough to tell about everything, so I'm showing you some ways that you can get more information in subjects that you're interested. Okay, so this genetic predisposition is mostly in children. In adults, there has to be some predisposition because all the triggering factors are much more frequent than HLH, but we don't have it for adults. Maybe it's sometimes combination of many factors. We don't know yet, but we can observe the triggers. So as I've said before, it's malignancy, infections, and autoimmune diseases. And in malignancy, especially T-cell lymphomas can trigger HLH, but also other hematological malignancies, and we have to remember about solid tumors. There can be also HLH after chemotherapy, which is not intuitive. I will try to show you some counterintuitive things, which are not so obvious. For me, it was not obvious at some point, because I thought, okay, we are diagnosing someone with lymphoma. He has a lot of bulk of mass of this tumor. There's a lot of cytokines. It starts HLH, So it has HLH triggered by lymphoma. It's quite understandable. But how someone can get HLH sometime after chemotherapy, like second, and not as CRS, not like tumor lysis, not like release of cytokines from the cells, but like after second, third cycle, for example, or several days after chemotherapy for lymphoma. And usually this is not due to lymphoma, due to malignancy itself. It's due to secondary infection, like for example, EBV, CMV reactivation, or some viral infection, which because of this immune suppression after chemotherapy. Okay, and we've got infections, of course, not only after chemotherapy, but as general. For EBV is very important player, and autoimmune diseases, especially Still's disease, and and lupus. Okay, and here we can see prognosis of treated patients in Polish registry, in Polish database. And we've got those triggers. I don't have such great quiz for you as with hepcidin, but you can think for a very short second for yourselves which group of those triggering factors will be will have the best prognosis and which one will be the worst. We've got autoimmune disease, and all those trigger HLH. Yes, autoimmune disease, infection, malignancy. Yes, and we can see it in Polish patients, but in large groups from Asia, from US, results are usually very, very similar. So we can see that MAS has a very good prognosis. Malignancy has a much worse prognosis, but what's interesting and then a bit terrifying, virus-triggered HLH has a prognosis very similar to this from malignancy. It's so you can think, okay, someone has EBV and HLH, it's much better than having, for example, lymphoma and HLH. It is a bit better, but here non-significant, but also in larger groups it wasn't significant. But it's a very serious disease, even if someone has only EBV. And how to memorize those triggering factors in different age groups. I've made some acronyms or used existing words for mnemotechnics. So for children, it will be Genesis, like Book in Bible, or this band with Phil Collins from 1980s, 90s. We don't have time for to listen to their hits, but I hope you know them. So it's not my favorite band, but it fits here. So we've got for Genesis, genetic background is very frequent because, as we said before, we've got those mutations which will can have very early onset. So in children, we have to look for genetic mutations in those classic genes, EBV and other viruses. And of course, if we have inborn defect mutation in bone marrow, we have to think of allogeneic stem cell transplantation. So early search for donor. Of course, usually it's triggered by infection, and siblings may be at risk, so you have to check also the siblings. And we'll discuss allogeneic stem cell transplantation at the end, but here it may be interesting to tell that there was a retrospective study, so it may be a bit biased due to this, but children who had mutation, like those siblings, and they were transplanted upfront, had better prognosis than ones who waited until onset of HLH, then putting in remission, and then allogeneic stem cell transplantation. So sometimes it can be like, maybe it also depends a bit on the age, on the mutation. It's for pediatric transplanters, but sometimes it can be worthwhile to transplant upfront such sibling. And adolescents, young adults, this is emerging important groups. So of course, all the items of genesis may be true, but also you have to think of RELI. It will be so rheumatic autoimmune disease, MAS, EBV, and other viral infections. You know that EBV is very popular among teenagers, and also lymphoma. And it may seem a bit early for adolescents, young adults to have lymphoma, but it happens. Like because the most important risk factor for malignancies is age, but so in adults we really look for malignancy, but here it can also happen. And even if we find EBV, we have to be cautious. We had a case of 18 or 19-year-old young man who had EBV viremia, but had also some suspicious lymph nodes. And finally, in lymph node biopsy, we found a lymphoma. So EBV plus HLH plus EBV viremia doesn't exclude lymphoma. And of course, some lymphomas are even associated with EBV. So you have to use your clinical reasoning and look for lymphoma in some cases. And so in older adults and elderly people, it's rely, but rely on, as you would say. Rely on, so rely is true, but O is for oncology and N is for neoplasm, because you have to always search for malignancy. And this is very important to remember, that when you've got adult patient with HLH without any obvious trigger, or this trigger is a bit suspicious, you have to always look for malignancy. So what's the natural history of undiagnosed HLH? There are first, like in children, a whole history can be, like whole onset can be really fulminant, that within days this child gets to the hospital and is in very bad shape. But in adults, frequently it lasts several weeks. We've checked if it doesn't affect prognosis, but not really. But so first dosomeone gets fever, some maybe infection symptoms, but it doesn't really alarm his family doctor, because he then comes as an outpatient, maybe gets some antibiotics sometimes he gets some medication, but then he gets worse. Then he gets to the hospital, first an inpatient, like it's as an inpatient, and if HLH is not diagnosed, he gets to ICU with multi-organ failure and dies, because by accident, people with infection won't get immunosuppressive treatment. And this is treatment for HLH because it's hyperinflammation, so you need immune suppression. So this is a review article from Polish Archives of Internal Medicine. I published this last year. It's open access, and this is and it can be useful for you as a consultant if you have patients on internal medicine ward or in some different hospital. You don't transfer the patient immediately, or those doctors want to know something or basic concepts or for young residents who have never heard of HLH, just as a beginning. It has some practical things like, for example, what to do with adult patient siblings, or how to observe patient. I will tell you, like, it's reasonable to assess all the HLH criteria yearly or every 2 years, depending on the risk, because people get, for example, higher ferritin over time or higher triglycerides, and then when they come back with infection, you know what is their baseline. So it can be useful for you to share with some internal medicine doctors. And of course, ICU. Unfortunately, some ICU specialists don't really believe in HLH. And I can't blame them, but at some point we should. And because those patients look like they have sepsis and then they die. There are very, very single patients who have real HLH among dozens, hundreds of those with sepsis, and many people with sepsis die because it's a very bad disease, not especially sepsis which requires ICU, severe sepsis in previous criteria, in previous guidelines. Yes, so this is nice editorial because it's in critical care, so it's intensivist magazine. So it has 2 pages. So if you have some ICU doctors who don't really, okay, it's some fancy hematology, we just save patients and make intensive therapy. This is good to show them, and it's very, very basic. And for differential diagnosis of HLH and sepsis, we've made a review with all the values, because sepsis is also intense inflammation, or at some point you can say hyperinflammation. So this is very difficult to differentiate. There were even some opinions that you cannot, and you should treat everyone as sepsis, because if you over-treat some patients with immune suppression, you get higher mortality. But I don't believe it's true. I believe that every patient deserves to have his own diagnosis, and some patients can be diagnosed with HLH. And to make a long story short, for example, patients without any hematological disease, just bacterial sepsis, if they get antibiotics, for example, they rather shouldn't have splenomegaly. But of course, our patients also get sepsis, and then they can have. So there are some things that we can say, or they shouldn't get cytopenia, because usually in infection, white blood cells should rise. And some of the patients can be diagnosed at ICU and treated in ICU, and they are very fresh from beginning of October this year. Guidelines from Histiocyte Society. We've made it over several years how to manage patients in ICU, and this is also Critical Care Journal. This is like very, very complex information how to proceed with such patients. And now a new thing that was in blood this April, that for this differentiation, I've told you about some clinical aspects, but here we go deeper. So you can see, remember those TCD38 cells, which are activated in HLH. And here we can see that if we've got subpopulation of CD38 high cells and HLA-DR plus cells high, this means that we've got rather HLH than sepsis, because this T cell response is high in HLH, whereas in sepsis it's not so high. T cells are not so active in sepsis. So this is a very good way of differentiation. It was published in Blood, but of course it's great, but we won't do it on average ward. Yes, it's not the main clinical practice. So you have to always think that, but maybe it can be done, but you always have to think in which patients. So, so this is important to have some clinical suspicion of HLH. Okay, historically there was primary and secondary HLH. Maybe you've heard of it, but it has some value, but it's not that simple, meaning that primary HLH was this genetic one, and secondary was secondary to something. But as we've said before, primary HLH with this genetic predisposition needs some trigger. Yes, so this is not genetic per se, but it needs some trigger, whereas secondary HLH has some predisposition. And as we can see from those works, and also adult patients have mutations, like in gray you can see mutations in HLH genes in Italian cohort. So adults also get those mutations. So it's rather a continuum of risk. Yes, for early onset and triggers which trigger in each patient. So important information from this is, if someone is 50 years old and he had a lot of infections, a lot of different diseases, and now he comes with very large lymphoma, very active with HLH, you treat the lymphoma, and probably until he gets a relapse of this lymphoma or another severe malignancy, he will not develop HLH. So he doesn't require allogeneic stem cell transplantation. Whereas the 6 month, yes, a very small child, like several months year old, gets like flu or whatever, like a very small infection, and develops HLH. When you stop HLH, it will develop another HLH with another infection. So this child needs allogeneic stem cell transplantation. Okay, and how to diagnose when we suspect it? So there are several systems. The most accepted and quite simple, with some, yes, I will tell you about some problems. It's HLH 2004. It was designed for children, not for adults, and it was for clinical study. So patient has to have confirmed mutation and symptoms, or 5 out of 8 criteria: fair fever, splenomegaly, cytopenia, high triglycerides or low fibrinogen, hyperferritinemia, as we've discussed, hemophagocytosis. But this is very important to say, hemophagocytosis is not pathognomonic for HLH. Another name for HLH, we'll discuss in a minute, is hemophagocytic syndrome. And some people tell, okay, I've got a patient with hemophagocytosis and some symptoms. He generally is unwell. So I say, okay, hemophagocytosis, symptoms, a lot of symptoms. Hemophagocytic syndrome, it's hemophagocytic syndrome, which is quite synonymous to HLH, give him etoposide. Not really. You can get hemophagocytosis in many different conditions. It's marker of long immune activation, I would say. Many patients who died after several weeks on the ICU, like 90% of them had hemophagocytosis. Patients with leishmaniasis can have hemophagocytosis. There can be even hemophagocytosis after blood transfusion. So this is, from one hand, hemophagocytosis is not pathognomonic for HLH, and some people tend to have such idea. On the other hand, you don't, you cannot exclude HLH based on lack of hemophagocytosis, meaning that if you have other symptoms and patient has HLH, you cannot, yes, but he doesn't have hemophagocytosis, so he cannot have hemophagocytic syndrome without hemophagocytosis, so it's not HLH. It can be HLH, it's only one of the criteria. Of course, it's valid and important. And hemophagocytosis can develop over time. So in later HLH, patient who didn't have it initially may develop it, whereas you don't redo bone marrow biopsy so frequently. So he had his first bone marrow without any lymphoma, without hemophagocytosis, and then he's getting worse, his cytopenia is worsening, all the other parameters, but you don't repeat after 1 week, for example, bone marrow. That's why you don't know that there is hemophagocytosis. But there doesn't have to be. This is very important. Okay, and low NK cell activity. This is important parameter, but it's not as great as we've suspected. NK cell activity can be lower in many states, including sepsis. And SCD25, it's soluble receptor for IL-2. It's very nice, but it's also not pathognomonic. It's elevated in many states, including lymphomas. So Professor Jędrzejczak proposed, previous head of my department and for many years consultant in hematology in Poland, for 20 years, I think. And he performed first bone marrow transplant in Poland in 1984. So great person with great clinical skills and intuition, developed simplified criteria, because those two are very difficult to obtain. So if patient fulfills 4 out of 6 criteria, but ferritin has to be over 2000, you can diagnose HLH, especially if it's Friday afternoon, patient is worsening and you want to give him steroids to save his life. Yes, so sometimes you have to act faster, not wait for SCD25 with turnaround of several days from some clinical center. Of course, it's good to consult some HLH experts or form some teams, but sometimes pediatric hematologists have better access or know more. But you have to save patient. So you can use this faster criteria. For MAS, there are some other criteria, for example, Ravelli criteria, which are much easier to fulfill, but in those diseases, they are still differentiating, but it's not the same as like real HLH caused by autoimmune disease, which is much more severe. And there is H-score developed in France. I've been in that center in Hôpital Saint-Antoine in Paris, and it has this advantage that it doesn't include those 2 parameters which are difficult to obtain. And it gives different number of points for each criterion. Some of them have 2 thresholds, like for fever, for hypertriglyceridemia. So it never hurts, but it adds transaminases and immune suppression. It never hurts to do it. In fact, it's very beneficial to do it. But you have to always remember that it's not definite diagnosis. It gives you some probability. And this threshold of 169 points frequently can be quite like too low for hematologic patients. because it was developed on different patients. So it's very nice to do it in parallel with H-score, with HLH 2004, but it doesn't mean that it's really HLH. Because H-score is for hemophagocytic syndrome, which is, I think, a bit larger. It is my opinion about all those a bit confusing names in a picture. So we've got HLH with most severe patients. Then we've got hemophagocytic syndrome, which is a bit larger. And in that H-score paper, they say it's hemophagocytic syndrome. Frequently, it's synonymous, but it's not precisely the same. We've got MAS with many milder patients from Ravelli criteria, but some of them also meet those more severe criteria and need, usually in MAS, they use steroids or anakinra, but some of them really need etoposide. And we've got CRS, which we will not discuss today. So it's cytokine release syndrome, especially after CAR T cells or bispecific antibodies. Because today we focus a bit more on diagnosis, because if you don't diagnose HLH, patients die, and if you give them at least steroids, you give them some chance. So this is very important to be aware, to know how to diagnose, to not over-diagnose. And in CRS, it's a bit easier, because if you gave someone CAR T cells and he's getting febrile and has all those symptoms of ICANS and whatever after day 2 or 3, after some days, you don't, like you expect it. It can happen. So it's not so difficult from diagnostic point of view or from awareness point of view, but of course it's great art how to manage it. And there's also name called cytokine storm syndromes. I think it incorporates all of them. So this is very complicated also in terms of terminology. And to make it even more complicated, there are also HLH disease mimics, meaning that there are patients who fulfill all the criteria, but it doesn't mean that they will benefit from immune suppressive therapy. You can tell that they have HLH disease mimics. It's concept from Michael B. Jordan, who is now head of Histiocyte Society. He has also this continuum was his idea. He's great at such things. So examples, for example, visceral leishmaniasis. I think it happens in India. I haven't seen it in Poland. But of course, tuberculosis, yes, we have. And some, so here, probably you can tell me about leishmania treatment, but as I understand, immune suppression won't do any good. You need to treat it with amphotericin B. Yes, and this is maybe for discussion, but those patients can fulfill all the HLH criteria, no matter which system for diagnosis you choose, and it doesn't mean they will benefit from etoposide. Yes, so this is important to know, that even if you have all the criteria fulfilled, it doesn't mean that you have your treatment. And for the recommendation of management of adult patients, they are from 2019, but they didn't change much so far. They are also from Histiocyte Society recommendations. And as we can briefly see, treatment depends on the trigger. So for CRS, the more important player there is interleukin-6, which in classic HLH is not so much elevated. So tocilizumab is base for CRS, whereas it's sometimes used in HLH or in salvage therapy, but it's probably not the greatest drug in this setting. And for infection associated, some patients get corticosteroids, IV immunoglobulins, but for example, for leishmaniasis, you get liposomal amphotericin B. So this is, so we treat with immune suppression, start with steroids, cyclosporin, and there are those protocols which are developed for children. This is important to know that they are for children. HLH 94 with etoposide and then cyclosporin after 8 weeks, and dexamethasone in tapered doses. And 2004, where cyclosporin starts immediately. And this is important to know that in the study of HLH 2004, there was no statistical significance, no significant advantage over HLH 94. But p-value was 0.06, not 0.5 or below 0.5, but 0.6. So it was close, but not enough. So advantage of HLH 2004 wasn't proven. So HLH 94 can be a protocol that you can rather choose, but it's not so obvious. Like, it's not because HLH 2004 is not good. It's because this change with cyclosporin, is it from day 1 or is it after 8 weeks? Probably it's not a big change. That's why the advantage wasn't shown. But of course, supportive therapy is much better now. But what's important, maybe I go, there are also very nice recommendations for use of etoposide in HLH, in adults and children. Here you can also find information about dose reduction. So this is good. And here it's summary which I've made for those regimens. HLH 94, 2004, you can see that cyclosporin is earlier, and HLH 94 or 2004, you can add cyclosporin if you really want, or you started with cyclosporin earlier and now you want to add etoposide. You can start with steroids and cyclosporin, at some point add etoposide, and don't want to withdraw cyclosporin. That adults get smaller doses of etoposide and once weekly. We've done it in adults twice a week, 150 milligrams in first 2 weeks. It was very toxic. Those patients already have cytopenia, and then they've got like neutrophils of 0 because it's very very often and higher dose. And this dose, smaller dose, and especially once a week, it was designed by Professor Jan Ingehenter from Karolinska, from Stockholm, Sweden, for influenza-induced HLH. He's also a great person in a HLH field. So HLH 2004 criteria, but HLH 94 regimen. But if you have some good idea why to use 2004, it's not much difference. It's not a mistake. And as we've said that in cytokine release syndrome, key player is in IL-6. In classic HLH, it's rather interferon gamma. And there is an antibody, emapalumab, which binds interferon gamma, and then it stops this pathway of activation. It's registered in US by FDA, but not by EMA. And it's very, very expensive, to be honest. But when you have a look at this graph, those of you who are very, I don't have the English word, but spotted, some of you probably spotted that you have JAK2, JAK1, those JAK kinases, probably it recalls you something that, they are mutated in, yes, myeloproliferative diseases. So we've got a drug. So maybe we could use ruxolitinib, yes, to block signaling from JAK kinases. And there are also trials with ruxolitinib in HLH with some promising results. And of course, you can use alemtuzumab, but then you should probably transplant this person. This is a very, very intense treatment. And very briefly, allogeneic stem cell transplantation, of course, in familial disease, of course, in second remission relapsed HLH and in CNS. And there are just last few slides because we are quite long on time. So basically, which type of conditioning should we use? Myeloablative or reduced intensity conditioning? So here there is a picture of a bear, and he is supporting himself on a beehive, like old one, like traditional in Poland in some regions. So beehive symbolizes bees. So bear symbolizes myeloablative conditioning with a lot of strength and power, whereas reduced intensity is like small bees which work very efficiently but slower. So which one is better? Data from pediatric trial from 2010 shown that reduced intensity conditioning is much better with 3-year survival of 92%, whereas myeloablative is only 33%. So it started trend towards reduced intensity conditioning, especially in pediatric, but also in adults. Moreover, if you think about it, it's not acute myeloid leukemia that where if you leave some cells, they can cause relapse. It's like you need some decent immune system, not a perfect one, but at least some reasonable cells which will kill the virus, which will work. So you don't even need 100% chimerism. And here you can see very nice work from Kai Lemberg and his team that they've summarized that if there with chimerism is always over 30%, you get much better prognosis. So reduced intensity seems to be a very good option. And we made, I've initiated analysis in BMT. And here you can see that in adults, but it's of course historic cohort, but one of the largest, there is no difference between reduced intensity and myeloablative conditioning. And now also there is more data from pediatric patients that also myeloablative conditioning may be beneficial, and those initial reduced intensity results are not so great, and it requires improvement. But in some areas it was like, okay, this RIG is so great, why should we put patients at risk and give them myeloablative conditioning? But some centers can have much more experience with myeloablative conditioning, have some problems with chimering testing. It can be problematic. So and all those immune suppression things. So if you want and feel more comfortable and have some idea that patient will benefit more, not only you, that it will be easier for you, but the patient will benefit more from myeloablative conditioning, you can do it. It's now under review, so it will be soon published, hopefully, and like second round of review. And here we can see results from HLH 2004 transplant. That here we've got probability of survival of 66%, but also RIG, MAC, trausulfan, everything. And in adults, this prognosis is much worse. So we should avoid over-treatment with unnecessary allogeneic stem cell transplants. But of course, there are many adult patients who require this. So from this choice between, so in adults, from this choice between bear and bumblebees, we didn't get anything reasonable. We got, it's a beehive, like traditional one, shaped in a shape of bear, and bees enter here from like this belly button. So those results are not great. Okay, so in summary, HLH is syndrome, not a disease. There can be multiple triggers which change with age, and we have to search for malignancy. There are many specialties involved. Hemophagocytosis is not pathognomonic. HLH disease versus mimics, we have to remember about this. HLH 2004 criteria, but HLH 94 treatment protocol, and RIC and MAC are possible in allogeneic stem cell transplantation. Thank you for your attention.
Thank you so much, Dr. Rafael. That was fantastic. Your passion for this particular disease appears immense. We have our colleagues here who have some difficulties and they will like to discuss with you. And until they show me the raise hand sign, I will take up some question from the audience. So one is a question regarding the use of tocilizumab. You mentioned about IL-6. So tocilizumab, any experience, any data?
We've tried it in one patient, I think without much success, and like it can be used in salvage therapy, but as cytokine data shows like it should help, because IL-6 is somehow elevated, but it's not the key cytokine. And if you want to block just one cytokine, probably it would be better to block interferon gamma.
Thank you. Dr. Neeraj, your question.
Thank you, sir. And thank you for the wonderful talk, Professor Makowitz. My question is two questions. One is, what is the role of anti-thymocyte globulin? Is there any role of ATG in HLH syndromes? And second is in adults in idiopathic, that is, we don't find a cause for the HLH. There's no malignancy, no apparent infection, and no apparent autoimmune disease. In such patients, what are the predictors of relapse, and how often do you transplant such patients?
Okay, so with ATG, there is also some kind of reaction, as you all know, that we want to stop with steroids. So there is kind of cytokine release, kind of this iatrogenic small HLH. So this is for sure. And I think it was also maybe a bit tested in therapy, but I'm not sure if it worked, because it's now it's not mentioned in salvage therapy. But of course, you have to remember that after ATG, you can have some febrile reactions. Yes, you have, and you give some steroids to avoid it. So it can even cause small HLH. And for transplant in idiopathic HLH, you have to be always doubtful about idiopathic HLH. Like in our cohort, I didn't discuss it, but there was this gray line with the worst prognosis, and it was idiopathic. But it wasn't, this prognosis wasn't so bad because patient was diagnosed for several months and all the tests were done and redone, and we couldn't find anything, and we decided it's idiopathic. But it was because patient, it's about patient, like it's for whole country, who arrived in very bad shape into hospital, had like very quickly entered ICU and died before all the tests were made. That's why it was idiopathic, because there is no no good answer why they developed it, and at some ICUs they don't really do PCRs for EBV for patients who are admitted 3 days before. So that's why they are idiopathic. For example, there was a patient who, not from our center, who finally had in autopsy very small metastases all over her lungs, for example, from some cancer of unknown primary, and they were too small for like CT scans, or I'm not sure if she had PET. It was also some years ago, but so you really have to think of your indications. Because you will think of allogeneic stem cell transplantation. Of course, some genetic testing, but it can lead you towards, because you find like perforin polymorphism, you have to really check this mutation. Is it a real mutation? Is it a polymorphism? If it's an adult patient, what was the trigger? Isn't there any, for example, lymphoma, which was stopped by steroids with etoposide? You can quite nicely put lymphoma in remission, not for long, but you can. So it can give you, of course, sometimes it's better to save patient from HLH and then have diagnostic problem, not to have a great diagnosis from autopsy. Yes, so of course, it's not a great mistake, but it can even save patients' life, so it can be a very good thing, but at some point, it can be difficult in your diagnosis. So you have to be really doubtful about this idiopathic HLH and really look for especially lymphoma malignancy. And for relapse risk, it's really hard to say because you don't know what was the cause. At some points you can try stem cell transplantation if you have this possibility and pay, but it's not mandatory. And of course, reassess HLH criteria every several months, for example, when if you don't transplant patient, because then patient comes with fever and you don't know if you have his baseline like 2 months ago, you can say, okay, he had ferritin of this and that, and now in infection is a bit higher, of course, I know, but then you're not shocked that maybe it's HLH relapse and it's a common flu.
Thank you, Dr.
Thank you.
And thank you, Neeraj. Dr. Hasmukh, your question.
Thank you, sir. Thank you, Dr. Rafael, for such an informative lecture. HLH is always difficult for patient and treating physician, so it is always good to have information regarding HLH. My questions: I have encountered 2 cases in the last 6 months. AML case post chemotherapy in cytopenia phase, they develop the HLH. Like all infective markers, CRP, procalcitonin, cultures, and scans are normal. High ferritin, high triglyceride, low fibrinogen. So in such a case, how aggressively would you treat the this HLH? Like there is always a risk of infection.
Yes. So if I understood your question, there was a patient with who after chemotherapy for AML developed HLH. Yes.
Correct. In cytopenia phase. Still,
and
they are
he
not
had
recovered.
already cytopenia.
Yes.
So so this is not an indication usually for etoposide, for more chemotherapy, because patient is already in cytopenia. You have to look for potential infectious triggers, and in treatment, like treatment-wise, as you may say, it's rather steroids and immunoglobulins. They are very, very good for patients in immune suppression. Of course, they are also immune suppressive, but at least they restore some antibodies. So IV immunoglobulins and steroids would be like the first choice for treatment after chemotherapy, or sometimes maybe yes, if the like what's the type of infection, maybe like different parts of immune system were suppressed, and if the immune suppression gets like smaller and patient regenerates, it might either get worse because HLH will become more accelerated, or maybe it can become a bit better because the infection will be treated. But as also in immune reconstitution syndrome, in HIV, you've got a bit similar situation, that you can have immune reconstitution, and then all those very small infections which were there start to trigger reaction from healthy immune system. Whether steroids, immunoglobulins, maybe some antibodies like for example tocilizumab, emapalumab, rather things like this. But of course, if you're in a great need, etoposide is there, or maybe you can think of some next cycles with etoposide there, so some regimens for AML with etoposide. But of course, for malignancy triggered HLH, usually the most important thing is to use the best treatment for the malignancy. But here we've got rather infection in this immune suppression. Hope this answers your question.
Yeah.
Thank you. Dr. Sharath.
Thank you, Professor Raphael, for a wonderful talk. So my question is, in the post-allogenic stem cell transplant setting, we see patients developing florid HLH, you've got hemophagocytosis in the marrow, it's probably a viral trigger, and then they kind of lose their graft. So just wanted to know what your experience is with this set of patients who are post-allogenic transplant.
This is very, very difficult because they already have cytopenia because they have cytopenia. They can have splenomegaly because either they had before or they have now a little bit. So this is very difficult to diagnose. I think in Geneva they were working on such patient, but it's really difficult to diagnose. And of course, hemophagocytosis in this setting can be because of like a bit of graft rejection, I would say, like that there are those macrophages who don't like the new bone marrow. So this is a very, very big problem, unmet need. It's really difficult to say. Some more immune suppression, but then this poor engraftment, and it's really difficult.
So we don't have access to NK and CD25 when we try to do the 4 out of 6 like you mentioned. So is there a role to pursue some more markers in this setting, because most of us are doing the 4 out of 6 like you mentioned?
Like especially in this set, because there's 4 out of 6 with ferritin over 2000, it's very important that this is for patient like first diagnosed, I would say, and there are no other reasons for those parameters. Meaning, for example, you can have a patient with liver cirrhosis, and then he will have ferritin because he gets it from this for his liver. Some cytopenia, like those cytopenias are platelets less than 100. So in cirrhosis, it's not a problem. He can have some anemia, even due to small bleeding, whatever. So then he has, and of course, splenomegaly due to portal vein hypertension. And he can get fever because everyone can get fever. Right. So then you've got a patient who has even no hematological disease at all, and you diagnose him with HLH because he has cirrhosis as usual and common cold. So this is very important with those criteria that they are easier to use, and you can save some patients, but in some settings they can be even deadly, because if you give etoposide or steroids to a patient with cirrhosis, it's not going to help him, it can be even worse. So I'm not sure how a CD25 behaves after stem cell transplant, but for example, if you have patient with lymphoma, you test for SCD25, you will get high result. And it's like this. So this is very, very complex. There is no one marker. Diagnosis of HLH after allogeneic stem cell transplantation, it's very, very complex.
Right. Thank you.
Thank you, Sharad. Dr. Mukul.
Thank you, Dr. Rafael. That was a very great talk, and you're answering all the questions very well. So I have a couple of doubts. It's a common problem, in fact, that we have a patient with a suspected lymphoma based on radio imaging and clinical features. And we are simultaneously able to make a diagnosis of HLH in him. But somehow, maybe because of the inaccessible nodes or small nodes or deranged low platelet counts or whatever, we are not able to biopsy the patient for lymphoma. How do you approach such cases? Should we start treatment for HLH or wait for some time in such cases?
Okay, so your question is that you've got patient developing HLH, but you cannot get diagnosis of a lymphoma, and you suspect it can be associated with lymphoma.
Yes, we have nodes on PET scan and other things like that.
It really depends, like on a clinical setting. If you have some time, you have to try to obtain the biopsy, but as I've said before, it's not great to have, to wait for too long, because there is also introduced this concept of point of no return in this, how internal medicine doctor can save patient with HLH, meaning that at some point the cytokine storm is so big that although patient is still alive and he's probably around ICU at this moment, if you introduce treatment, you cannot reverse it, because this treatment doesn't stop the cytokine storm immediately. It just stops, for example, production. It helps, like giving etoposide or steroids, it should help, but this storm may be too big and you cannot get patient back to health. So, so you cannot wait for too long. Sometimes, I'm not sure how is it in your center, but in our center, we've got, since some years, a very nice team of radiologists who perform biopsies under CT. But you shouldn't have too big coagulopathy for this. This is the problem. Because you have some platelets, because you've got also frequently coagulopathy in HLH. But if you can transfuse platelets, plasma, and get some reasonable coagulation, maybe you can try biopsy under CT. And worst case, if patient is worsening and you cannot really hope for any type of biopsy, you have to give him steroids. You can even give him etoposide. And then you tailor your treatment. If you want to really treat him and have him cured for several months, or you just want to control it and then try to repeat biopsy in a more difficult setting, meaning diagnosis for pathologist. Because after steroids, even this pathological interpretation will be much more different. And one more thing about treatment in lymphoma, because we are aiming at the best treatment for this type of lymphoma, we don't know which one it is, but usually in HLH, you can try to get from, instead of CHOP, CHOP, you can also add etoposide to some cycles. And sometimes when patient has HLH and is in too bad clinical condition that you cannot start with, for example, you've got DLBCL diagnosis, you have your lymph node, but you cannot start treatment because patient is not in a good shape because of HLH. You can start with some pre-treatment, but not with steroids and vincristine as usual in DLBCL in elderly patients, but with some etoposide and steroids to stop the HLH, and then go with your chemotherapy, because some people, if they see HLH 2004 or 94 protocol, they want to go for full protocol, for full 8 weeks, or even with those maintaining doses for some time. But this is for small children to survive without relapse until their allogeneic stem cell transplantation. And in adults, if you control HLH, you know it's lymphoma, you go for chemotherapy. Or you can, or if you even don't know, like in this idiopathic that we've discussed before, you can stop it earlier. Like, of course, all the parameters have their time to normalize, but if everything gets well, you don't have to go for 8 weeks. You can stop at, for example, everything seems quite nice at 4 weeks, maybe you can go for 5 or 6, but it's not obligatory. You have to go for 8 weeks of this initial treatment.
Thank you, Dr. Mukul. Dr. Ruchi. Unmute yourself, Ruchi, or somehow we are not able to hear you. You are unmuted.
Sir, I'm unmuted. Can you hear me?
We can hear, but it's very, very quiet.
Very feeble. Be closer to the mic.
So it's even not muted, it's very quiet.
Yeah. Okay, Ruchi, will come back to you. Dr. Mapali.
Thank you so much, sir, for this full lecture. I have a question, like if we have a case who has already been previously treated and diagnosed with HLH, and now the patient has presented with fever, should we again keep the suspicion of relapse of the disease in our mind?
Mm-hmm. Yes, of course. But then we have to avoid like over treatment, that somebody comes to us like had HLH, I don't know, as a teenager. Now he's in his 40s or 50s, and we don't have, and now he has ferritin, like high ferritin, high triglycerides, and fever. So we panic and we start with steroids and etoposide, and he's in a reasonable condition, because sometimes you have to panic and act very quickly, of course. But let's say he's about like outpatient. So of course you have to think about relapse, but of course you have to think about new trigger. Is it the same infection? Or you have to think that I was told about this 50-year-old man who had HLH as a teenager. In the meantime, for example, he can have hemochromatosis, he can have some dyslipidemia, and now he comes with a bit elevated ferritin because he has this hemochromatosis. He has some dyslipidemia, so he has elevated triglycerides. Also, he has some infection. He has this fever, but it can be like maybe bigger common cold or small flu or even bigger flu. And it can be all. Or he may develop a lymphoma. He can have some other type of cancer. So problem with HLH is that, okay, we've got this question about flow cytometry. Okay, so I will answer it in a second. Yes, so you have to always think about relapse, but it's not like, okay, someone had DLBCL, he's in remission, now he has relapse of this DLBCL. Of course, it's more malignant, like it's after selection of cells and everything. It's not totally the same disease. That's why you don't start with R-CHOP again. But okay, it's the same disease, it happens. It can be the same. It can be like usually new trigger, new situation, or it can be not HLH at all. Okay. That is why it's important to repeat those basic tests every, for example, year.
Okay. Dr. Rafael, you can answer the question in the chat box.
Yes. It was, yes, I will double check, but it was, what's the role of flow cytometry in diagnosis of HLH? Yes, so initially there was not so much because you cannot see hemophagocytosis in flow cytometry, I think. but maybe it's somehow possible. But now it's getting higher and more important, because first you can diagnose some interleukins with some beads and flow cytometry based techniques. So this is one thing, but very important thing is you've got, we didn't discuss in detail NK cell activity, but mistake that some people do is they do flow cyt, like it's good that they do flow cytometry because, for example, they suspect lymphoma or some other disease, and they see that there is low number of NK cells. So they say, okay, so this is a mistake that people do with flow cytometry. Then we will get to important thing that you should do with flow cytometry. So it's very important to do flow cytometry because you can diagnose lymphoma. This is important, but not to do this thing that I'm talking, that people find low amount of NK cells. So they say, okay, if I've got very few NK cells, their activity will be low because there is not enough of them. So check, I've got low NK cell activity, and they are very happy that they've got another criterion, which is not true, because in cytopenia, you've got normal, like smaller number of perfectly normal NK cells. You have to check each cell, how each cell is active. So it's like a general who sees, like there is, looks at the soldiers. There is a small group of soldiers. Of course, their strength to attack is quite small because the number is not very large. But you have to assess how fierce are the soldiers. Yes, are there new recruits, or are there very good veterans and very seasoned soldiers? Yes, so this is what we are testing, and previously it was done with K562 cells and a chromium radioactive assay, and we are really trying to avoid radioactivity in diagnostic process when it's not needed, and usually it's not. We don't even use Schilling test anymore. So so this is a problematic thing. And I don't remember who, but it was found that inside, when I saw you those granules, when they release perforin and granzyme, inside they have marker CD107A. So usually, because those the granules, if they exocyte, then they stay on the on the surface of the cell, yes, as a cell membrane. So if you find CD107A with flow cytometry on the surface of the cells, it means that cytotoxic activity works. And if you don't find it, it means it doesn't work. So this is very important role of flow cytometry, that you can replace checking for NK cell activity with this test. It was published several years ago in Blood, like maybe 5 years ago. So you can check for this. So this is important role of, but with NK cell activity, you can think that, okay, if there is no activity of NK cells, we've got this pathognomonic element. And of course, it's important in functional testing in children, and then for those mutations and everything, but NK cell activity can be transiently lower and then go back to normal, for example, in bad sepsis. So it's not that easy that you find individual with lower activity and you say, it's HLH, no matter what criteria. In children, maybe yes. In adults, not really. I hope it answers.
Thank you. Dr. Nidhi?
Now we've heard it.
Dr. Nidhi?
Thank you, sir, for that very informative talk. My question to you is that I would like to know which adult patients of HLH would you consider for testing for genetic alteration? Like, say, if I find a patient, I diagnose a patient of with EBV associated HLH, still would you consider looking for?
You muted yourself. You muted yourself at the very end, but
yeah.
Sorry,
so the last part was like, even if I diagnose a patient with EBV associated HLH, as we know that we need a second trigger even if we have a genetic alteration. So should we test all of them for a genetic alteration, or if we find one cause, then we should say that it is just a secondary HLH?
Like it really depends on two things. Okay, so basically like teenagers, young adults, probably yes, but it depends on how, like on your access to genetic testing. Is it affordable? Is it close? Because it doesn't hurt the patient to have some blood sent for testing. So it's not invasive, like generally it, like in, I don't know, 20 years or whatever, we would do CBC to everyone and we will do genetic, like they will already have genetic testing, like testing for phenylketonuria when children are born. So, so it depends on the resources, but then like testing is one thing. Second thing is interpretation of those tests, because then you can find, for example, perforin polymorphism, which is like A91V. They've made a nice trial in Australia. I think there was a large cohort. They've checked what's the, and they were for some cardiac, I think, trials that was assembled. And they've checked that there is the same frequency of this allele in people in their 70s as in children or something like this. So there are some polymorphisms which can be associated with something, but they don't really cause HLH. And then if you find such polymorphism, there may be urge to transplant someone. And of course, younger patients, I didn't show this, this have better prognosis in those transplants than this roughly 50%. But still, allogeneic stem cell transplantation is a big thing. And if you can, like if you need it, it's great that we have it. But if you don't need it, I would rather avoid it. So this is the problem of genetic testing. Like if it's accessible, you can always do it, especially in young patients, especially with not maybe, as we said, neoplasm malignancy, because if someone is in his 50s and he's still transplant eligible, or even early 60s, and has some malignancy, of course, he won't get HLH again before he gets relapse or another malignancy. But so young adults, especially with some albinism, there are some syndromes which are associated with hypopigmentation, and some dysmorphism, some other clues. Some may be unsolved deaths of children in that family. If there is some familial and people are young or young adults, and it depends on the availability. But then you have to be cautious that results that you get can be problematic.
Thank you. Dr. Karuna? Dr. Karuna, are you there? Yeah.
So Dr. Nafel, I have a doubt. So we often get consults from our medicine colleagues, regarding patients who have infection, most commonly bacterial infection and secondary HLH. Most of the times these patients will be sick, and it's very difficult to use the protocol drugs mentioned in the protocol over here. Often we think, should we use even steroid in such cases? So in cases with bacterial infection and HLH, so how do you choose drugs here, and how do you dose the drugs? That is my first question.
Yeah, let him answer your first question. Yeah.
Okay, so if I understood you correctly, because there was a bit of problem with voice transmission, your question was about bacterial infection triggered HLH and about the treatment, yes?
Yeah. So how do you dose and choose the drugs here? So the steroid, cyclosporin, etoposide, right? So
yes. So rather, I would avoid etoposide and try with antibiotics. Sometimes maybe it can be such a big sepsis that it will require ICU, but rather antibiotics with some steroids, maybe immunoglobulins. Sometimes also, what I didn't mention are plasmapheresis or dialysis with special membranes which capture the cytokines. This can be helpful just to remove mechanically the cytokines, because in real bacterial infection, you don't want etoposide to cause cytopenia. And you need some inflammatory reaction to fight with bacteria. And it's much shorter process because, for example, with EBV, you have to somehow control the situation. You cannot just leave it, and you don't have much effective drugs against EBV. Whereas here, antibiotics plus immune response should somehow help. But of course, as we've said, many people die with sepsis, not to mention sepsis with HLH. But rather not etoposide, some milder methods, immunoglobulins, steroids, of course, antibiotics, and maybe plasmapheresis or cytokine absorption.
Thank you. Your second question, Karuna?
Yeah, same thing, sir. So the indication of immunoglobulins and plasmapheresis.
Okay, same question. All right. You answered that.
Okay.
Do you have another question?
No, sir. That's it. Thank you.
No. Okay. So your raise hand sign you can remove. All right. Dr. Raphael, may I request you to go through the question box, see the questions, and
okay, there are questions and answers, 17 of them.
There are plenty of them, but what I'll do, I will just answer the quiz question for the postgraduates, and you take 3 more minutes to go through those questions. Some of them may be just repeat, and others may be new ones. Okay. So I will just give a break to Dr. Raphael and give you the answer to the quiz. I'll share my screen. Fine. So the quiz was related to hepcidin. You were shown a picture and 11 conditions were shown to you. And you were supposed to pick up a wrong one. And that was the picture shown to you. You know that hepcidin is produced from liver and it is a antimicrobial substance. Therefore, it is called sidin. And it's a 25 amino acid structure which is connected by 4 disulfide, those yellow bars. Now, the discovery of hepcidin has helped us in understanding iron metabolism, iron deficiency, iron overload, and anemia of systemic disease. Now, at the top, all these 5 conditions, they do increase the levels of hepcidin, and they were all correct because in all these conditions, you want the hepcidin to block the iron absorption, block the release from the macrophages. So kidney problem, when you give transfusions, when you give iron therapy, when the iron stores are depleted, and this genetic condition. And hepcidin production is suppressed in most of the conditions that are shown you at the bottom, except the one over here, number 10. Infections and inflammations actually increase the production of hepcidin because, as we just talked about, hepcidin is a natural substance to control the infection. So infections increase production of hepcidin, so that can act as an antimicrobial, and that's the natural defense system. So this was the wrong one. So you were supposed to answer 10. All right. Now, again, 75 of you have tried to answer, and we have got how many? 5 and 6, 11 answers correct over here. And of course, I'm not showing you the first, which is the fastest finger fast. In the order of your reply from second one, these are the guys who have given the correct answer. Dr. Ramesh B, Dr. David V, Dr. Gunjan Prasad, Dr. Dheeraj Choda Varapu, Dr. Akanksha Garg, Dr. S. Kanan Ramamurthy, Dr. Yoga Lakshmi, Dr. Sharifa Mai Saraf Sayyed Azim, Dr. Ketan Nathani, Dr. Sasitha Sathi Yanathanam, and Dr. Sumit Mirk. And now we come to the fastest finger first. And the fastest finger was we have a new winner this time, Dr. Biswa Prakash Patri. Dr. Biswa Prakash Patri is a senior resident doing DM hematology at Guwahati Medical College, Assam. So heartiest congratulations, Dr. Patri, for winning. I know you have been attempting from May onwards, and this is the first time you got the correct answer. So that's fantastic. You never gave up, you kept answering, and we kept receiving your answers. Send us your details and we'll send you your prize money. Thank you so much. And we come back to our speaker, Dr. Rafael. So whatever you want to answer from the question box.
Okay, so there is a lot of great questions. About 3 of them are about dengue, so I don't have any experience, so I won't add anything in this in answering this. About COVID, there was the idea that people die from COVID because of HLH, but it's a very small subset, and it's different. There are some papers about it. I won't go into detail, but there are some very, very, very important thing. So we've discussed that if we have a patient with lymphoma, we go for the lymphoma treatment, but with some maybe pre-treatment if it's needed. This is important question. What is recommended method to screen for EBV, PCR, or viral capsid antibody? Rather PCR, probably. If it's if you can access this, it's the one we use. But maybe others can be in your center also done. But of course, antibodies can be not enough. And this is important question. Do you do bone marrow biopsy for diagnosis? Yes. This is very important. First, to assess hemophagocytosis, but sometimes you can have other criteria and don't need it, like in this graph for ICU. But you have to also check for some hematological malignancy. So you can, for example, find lymphoma in this bone marrow, like 5% infiltration. There can be like quite mild cytopenia, not caused by infiltration of the lymphoma, and there can be some enlarged lymph nodes, but in infection who doesn't have some enlarged lymph nodes. And then there can be, you can find lymphoma thanks to this bone marrow biopsy. So this is very important. Okay, clarify if adult patients need mutation study. We discussed it. How high should be ferritin to suspect HLH? So there were even some patients with ferritin lower than 500 diagnosed with HLH. Maybe not in some. I think in US there was a big group, and they've diagnosed some. But usually it's like around at least 2,000. But like you should always suspect. But several thousand, like 5,000, 7,000, the more you get, the more specific it will get. If you have 50,000, like 1 in 5 patients probably will have HLH. The problem is that you miss all those with small with smaller values. So usually above 10,000, 7,000, and if it's like 3, 4, 5,000 and it's not, and you feel that it's hyperferritinemia is not well explained by other factors, and it doesn't cost much to do fibrinogen, triglycerides, CBC, check for splenomegaly, and then you've got some picture. Maybe not bone marrow in everyone, yes, but Can you get HLH after transplant? We've answered this. Which adult patient should be taken for allo relapse, refractory disease, and mutations? But in adults, this is tricky with mutations. We've discussed it. I'm not sure which drug for EBV would be much helpful here. So, which solid tumor most commonly causes HLH in adults? I'm not sure about statistics. Like they are not very intense in causing HLH, but they are much more frequent than hematological malignancies. We had some patients with breast cancer, I think, but it's not. I'm not sure if there is any common type of cancer which will cause much more HLH. Maybe some smaller types. So you have to think of the cancer generally. Okay, and I'm not sure what is the because there is question about pediatric patients and their profile in India and what's in West. I'm not sure what's in pediatric hematology in the West. And there is another very, very important question. If there is mild cytopenia, can we watch and wait? And this is very difficult because HLH is self-accelerating and it's developing. So generally you shouldn't wait, but maybe it's not HLH. So this is the problem. If you have really diagnosed, and as we've discussed today a lot, fulfilling the criteria doesn't mean that you have diagnosis. It's not as easy as with DLBCL. You've got your lymph node, you've got your diagnosis, you go with R-CHOP and you're done. Here you've got your criteria. It only tells you that it's really bad. You've got objective measure that situation is serious. And you don't know what causes this, and depending on what caused this, you choose treatment, but you know it's bad and you have to be, and you're in a hurry. So if there is mild cytopenia and some mild symptoms, maybe you can a bit wait, but wait with treatment, but proceed with diagnostic procedures, because you can't do it everything immediately. You've got an outpatient, even not on Friday, but on Thursday, and then what? So you can wait, but actively diagnosing. If it's HLH, what's the trigger? If it's, or maybe it's not HLH, or maybe it's some coincidence and it will go, but not like, okay, you've got HLH, but it's not so big, like a smoldering myeloma or monoclonal gammopathy, like let's meet in 3 months and we will see. Yes, of course, I know that it wasn't your idea, but it's not like watchful waiting and we will see. It's more like we use this time that the patient is not so bad at the moment for diagnosing what's the cause. Role of plasmapheresis, we've mentioned in CRS. There are separate criteria for CRS, and you can tell. And then how big spleen can become in HLH? Can you see massive splenomegaly? Yes. You can see we had even some patients undergo splenectomy. And with splenectomy, it's an interesting thing because it can be also helpful in treatment when you remove it. The problem is that patient has hole in his abdomen. So then for wound healing, steroids are not so great. So this is a bit tricky because if you remove spleen, you can you can diagnose lymphoma in the spleen. You can have even some benefit for whole HLH, but if this benefit is not so big and you've got very active HLH like 5 days after surgery, and there is still open wound, then you're in a big problem. So it's not so great, but general splenomegaly used to be used and maybe can be used in some causes, and this splenomegaly can be massive. can be massive. And last question, and dengue virus. I don't really know.
Yeah,
yes.
that's the last question, so that's okay. I may just add for those guys who are asking repeatedly about dengue. In dengue, it just depends upon how the severity of the problem is. Most of the time, we can get away by using steroids, occasionally IV gamma globulin, as the disease is self-limiting. Within a week or two, things settle down. So those who, unless you have got a dengue shock syndrome, dengue hemorrhagic, and patients are critically ill, then you can lose that patient. But otherwise, most of the cases, even if the ferritin is 10,000, 20,000, 30,000, patient is stable, just a little bit of steroid and occasionally IV gamma globulin, you can manage them. Okay. That was the question answer box. If there is any more questions from the faculty here, I don't see anything now. So yes, Dr. Mukul, you have a question?
Hi, sir, my question is about CNS prophylaxis in patients with HLH. So does it vary if the etiology of HLH is different, if it's infections or malignancy, or if it's primary or secondary? Does the CNS prophylaxis vary?
Like so, in HLH 2004 protocol, there is this intrathecal prophylaxis.
Yeah.
And frankly, in adults, we don't really use it as fixed prophylaxis. As like in children also, you don't have CNS symptoms. So my intuition is that in children, you can have even seizures due to high fever, and which doesn't occur in adults. Yes, and as they grow, they don't have the seizures. So it's much easier for children to develop some CNS symptoms in HLH, and of course, if you suspect lymphoma in adults, probably you should do at least one intrathecal fluid testing, but we don't routinely go with several intrathecal prophylaxis rounds. Yes, so this CNS disease, maybe it's also a bit underdiagnosed. It depends on the cohort. I've seen some cohorts when there was only like one patient in several dozens, and in some that was reasonable percent, but I'm not sure how was it diagnosed. That people had some symptoms, but maybe they were just in high fever, and they were not greatly, let's say, working with their CNS, or they had really big symptoms. I'm not sure.
Thank you, Dr. Mukul, for that question. We have Dr. Manoj to give the official vote of thanks, but just before that, on behalf of Mumbai Hematology Group, I am extremely grateful to Dr. Rafael and all the discussants and everybody else. The session was fantastic. I mean, it's rarely that we discuss this disease, and with an expert who has been advising his country, this was tremendous. And I think the care of HLH in this country and all those who have been listening will be very, very different now. You have been very helpful to us. Dr. Manoj.
Indeed, I completely echo what Dr. M.B. Agarwal sir said. HLH treatment after these 2 hours would be different. Thank you indeed, Dr. Rafael, for those words. Professor Dr. M.B. Agarwal sir, thank you indeed for pulling all the wonderful delegates throughout these 20 months and more. Dr. Sandeep Shah for those pearls of wisdom, expert discussions today, for those inciting interactions, Dr. Aditya, Dr. Dipesh, Dr. Hashbuk, Dr. Javed, Dr. Karuna, Dr. Moipali, Dr. Mukul, Dr. Neeraj, Dr. Nidhi Jain, Dr. Pratibha Singh, Dr. Pravas, Dr. Ruchi, and Dr. Sharad Damodar. So today we have 16 countries who have logged in, and I must thank them. India, Bangladesh, delegates from Pakistan, Malaysia, Myanmar, Sri Lanka, Australia, Algeria, UK, Indonesia, Iraq, Guyana, Cambodia, Singapore, USA, and Sweden. Thank you, all of you. All of you have a wonderful day and a wonderful Sunday.
Thank you. Thank you very much. It was great pleasure to talk with you, and the discussion was really great. Like we covered all the subjects, I would like to invite you to two things. One, there is a Histiocyte Society for those who are more interested in HLH, and there will be hopefully Congress in 1 year in Stockholm, Sweden. So this is interesting option, and there are also some seminars for members every several months online. And also I'd like to invite everyone to EHA, European Hematology Association, especially young hematologists, but it's up to 36 years of age. There is young EHA, which I'm a member of the committee, and there is also for young hematologists, there is preferential fee for participation in the like for membership, and there is access to many educational materials. So it's great thing, and I invite you to join us. And thank you very much for this great morning. Thank you for great discussion. Thank you for all your hospitality. It was really very great pleasure to be online with you.
Thank you, Dr. Rafael. And thank you, Dr. Mukesh.
Thank you. Thank you, sir. All of you have a wonderful day. Thank you.